Welcome back to the Deep Dive. Today we are tackling what is, well, probably the most critical area of professional decision-making you will ever face.
Absolutely.
We're talking about that intersection of consent, capacity, end-of-life care, and, all the fairness duties that really hold the NHS together.
Sees the absolute bedrock of safe practice.
Our mission today is to really cut through the noise. We want to synthesize the key guidance from the GMC's Good Medical Practice, from the Mental Capacity Act, and of course from huge case law like Montgomery.
And the goal is to give you frameworks that you can use immediately, especially for the MSRA SJT. This is where the theory meets the reality of the ticking clock.
Exactly. And to really set the scene, let's just jump straight into one of those classic scenarios that, it just gets your heart rate up. Okay, so imagine this. You're on call. An adult patient is brought in. They're profoundly unwell, delirious, hypoxic, and you're pretty sure they have raging sepsis.
The classic picture.
They urgently need IV antibiotics, fluids, the works. It is absolutely time critical. But as you go to put a cannula in, the patient pushes your hand away and shouts, "No treatment. Get away from me."
Right.
They're agitated, confused, and they're alone. No family around. You know that every minute counts. What do you do first?
That's the question, isn't it?
Do you just stop and respect the refusal? Or do you decide, well, they clearly lack capacity and you just get on with the treatment?
That tension is everything. And if we had to boil down all the law we're about to cover into, one single truth, it would be this.
Yeah.
Lawful decision-making requires you to support the patient's autonomy and understanding first. Only after that do you move to applying capacity tests or fairness criteria, and all of it has to be meticulously documented.
So you can't just jump to what feels like the safest option.
No, you can't jump to the paternalistic option of treating them without first trying to uphold their autonomy.
Yeah.
That attempt, and proving you made that attempt, is what the exam is really scoring.
And that really explains why we're doing this deep dive. These principles cover the core of GMC Good Medical Practice, especially Domain 2.
Exactly. The bit about patience, partnership, and communication. If you get consent or capacity wrong, the consequences are, well, they're severe. You could be looking at a claim of battery.
And for the SJT?
For the SJT, these scenarios are everywhere. They are high frequency, and the exam rewards that structured, lawful thinking. It penalizes the emotional, rushed reaction that might feel right in the moment, but is, legally and ethically wrong.
So let's build that structure. Let's start with the absolute foundation. Consent. The DMC is so clear on this. Consent is a process. It's not just about getting a signature on a form. For it to be valid, you need 3 pillars.
Capacity, voluntariness, and informed choice.
Right. And that last one, informed choice, is where everything really changed, didn't it, with the Montgomery ruling?
It was a complete game changer. Montgomery versus Lanarkshire Health Board in 2015 essentially buried the old paternalistic standard.
The Bolam test.
The Bolam test, exactly. That was the one that asked, would a responsible group of doctors have told the patient this? That's gone.
So what replaced it? What's the new benchmark for how much we have to tell our patients?
The benchmark shifted from the doctor's perspective entirely to the patient's. The rule now is that you must take reasonable care to ensure the patient is aware of any material risks in a treatment.
And the alternatives.
And, crucially, any reasonable alternatives to that treatment. And that includes the alternative of doing nothing.
Okay, that sounds much broader. So how do we define a material risk? That feels quite subjective.
It is subjective, and it's meant to be. A risk is material if one of two things is true. Either a reasonable person in that specific patient's position would think it's significant.
Okay.
Or if you, the doctor, know or should know that this particular patient would find it significant.
Can you give us an example of that?
Sure. Let's say you have a professional pianist who needs minor hand surgery. There's a 1 in 1,000 risk of slight nerve damage affecting fine motor control. To the general population, that might seem like a tiny, insignificant risk, but for that pianist, it's career-ending. It is absolutely a material risk, and you have a duty to discuss it in detail because you know it's significant to them. You have to tailor the conversation.
So it's not enough to just describe the option that we think is best.
Not at all. You have to lay out all reasonable alternatives. And again, doing nothing is almost always a reasonable alternative that needs a proper discussion. An SJT answer that suggests you glossed over an alternative will always score badly. It's a direct violation of Montgomery.
And this leads to the ultimate expression of autonomy, which is respecting a patient's refusal to have treatment. This is so hard for doctors. If a capacitated adult refuses treatment, even if it could lead to their death, We have to respect it.
It's where our clinical instinct to save a life clashes directly with our legal duty. But the law is crystal clear. A capacitated adult has total sovereignty over their own body.
So our role isn't to persuade or pressure them?
No. Your only role is to ensure that their refusal is truly informed, that they genuinely understand the material risks of saying no. After that, you document that conversation meticulously, offer support, but you cannot treat them.
Okay, so to help structure this, especially for the exam, let's use a mnemonic. Let's go with GCA.
Good one.
So C is for check capacity. If you have any doubt, you go straight to the MCA framework.
Essential first step.
H is help understanding. So using things like teach back, giving them time, using communication aids.
And maximizing their ability to choose.
O is for outline alternatives, and that includes doing nothing. I is for individualized material risks, just like we discussed with Montgomery.
Tailor it to them.
C is confirm the decision, making sure it's voluntary, informed, and they have capacity. And finally, E, enter it in the notes. Document everything.
That framework is your safeguard. It proves you've respected their right to make what you might think is an unwise choice.
Now, what happens if the patient is a child? The whole legal landscape just shifts completely, doesn't it?
It does. And the first thing you have to do, the highest yield action, is check their age. The law changes dramatically at 16.
Okay, so let's start with children under 16. What's the rule there?
For under 16s, we use the principle of Gillick competence.
Right, from the famous case.
Exactly. It means a child can consent for themselves if they can demonstrate sufficient understanding and maturity to grasp the nature and the implications of that specific decision.
So it's decision-specific, not just about their age.
Absolutely. A 14-year-old might be Gillick competent to consent to having a blood test, but probably not for major heart surgery. You have to assess it each time based on their maturity.
And if they are Gillick competent, what's our duty to their parents?
You should always encourage them to involve their parents or carers. It's almost always in their best interest to have that support.
But you can't force them to.
You cannot insist on it. If the young person is competent, their decision is the one that matters legally, as long as there are no overriding safeguarding concerns.
And that brings us to an even more specific framework, the Fraser pathway.
Yes, and this is prime SJT territory because it's so specific. The Fraser criteria apply only when you are providing contraception or sexual health advice, including termination, to someone under 16.
And there are 5 criteria they have to meet.
All 5. 1, they have to understand the advice. 2, you can't persuade them to tell their parents. 3, they're likely to continue having sex anyway.
Okay.
4, their physical or mental health is likely to suffer without the treatment. And 5, it is, on balance, in their best interests to treat them confidentially. You have to be satisfied on all 5 points.
What about the slightly older group, the 16 and 17-year-olds?
That's simpler, thanks to the Family Law Reform Act. They are presumed to have capacity to consent as if they were an adult.
So you treat them just like an 18-year-old?
For consent, yes. But, and this is a key distinction for exams, their refusal is slightly different. If a 16 or 17-year-old is refusing life-saving treatment, that's a massive red flag.
What do you do?
You must get urgent senior and probably legal advice. A court can still authorize treatment against their wishes if it's in their best interests. That's a power that's generally lost once they turn 18.
That subtle difference is exactly the sort of thing they'd test. Okay, let's use another mnemonic for this pathway. Age safe.
Good.
A for age and urgency. G for Gillick, test for the under 16s. E for explain Fraser or parental responsibility. S for safeguarding and confidentiality limits.
Always be clear about when you might have to break confidentiality.
Then A for agree a plan, F for follow-up, and E for enter it in.
Enter it in the notes.
That structure stops you from making the classic mistake of just defaulting to the parents, which would breach a competent young person's autonomy.
Right. Let's circle back to where we started, the delirious patient with sepsis.
Right.
When you doubt an adult's capacity, you have to use the Mental Capacity Act 2005.
Yeah.
That is your legal roadmap.
It is. And the scoring structure in the exam always follows the same path. Support first, assess second, best interest last. You have to go in that order. Let's quickly run through the 5 core principles of the Act. They really set the tone.
Please.
Okay, number 1. You must always presume capacity. The burden of proof is on you to show they don't have it.
Are crucial.
2. You must take all practicable steps to support their decision-making. 3. Making an unwise choice is allowed. That's a big one.
A very big one.
4. If they lack capacity, any decision has to be in their best interests. And 5. It must be the least restrictive option.
And out of all of those, Principle 2 support decision-making is where you get the most marks in the SJT. It's the step people rush past in an emergency.
So let's apply that to our septic patient. They're confused, they're hypoxic.
Yeah.
How do you support them?
This is where good medicine is also good law. The impairment is delirium from sepsis. So to support their capacity, you have to treat the reversible causes.
Like giving them oxygen.
Exactly. Give them oxygen, check their glucose, make sure they're not in pain, give them flutings, put them in a quiet, calm environment.
So you medically optimize them first.
You medically optimize them, and you provide communication support like an interpreter or using the teach-back method. Only when you've done all of that can you say you've taken all practicable steps. If you skip that, you're jumping the gun and you'll lose marks.
Okay, so you've done all that, you supported them, but you still think they can't make the decision. Then you move to the formal 2-stage test.
Then and only then. And remember, the test is always for a specific decision at a specific time.
So what are the 2 stages?
Stage 1 is the diagnostic test. Is there an impairment or disturbance of the mind or brain? In our sepsis case, yes, it's the delirium. If there's no medical cause, the test stops there and they have capacity.
It's stage 2.
Stage 2 is the functional test. And this is where you check for the 4 abilities. They have to be able to do all 4.
Which are?
1, understand the relevant information. 2, retain it long enough to make the choice. 3, use or weigh that information to come to a decision. And 4, communicate their decision back to you.
Let's go back to the patient. We've given them oxygen. We explain again. You have a life-threatening infection. You need these antibiotics. How does the functional test apply?
So they might understand you for a moment. They might retain it for 30 seconds. But limb 3, use or weigh, is often where a delirious patient fails.
Can you give an example?
They might say something like, I understand you want to give me the medicine, but the walls are melting and I need to catch the bus. They are fundamentally unable to weigh the benefit of the antibiotic against the risk because their thought process is broken by the delirium.
And because that failure is caused by the stage 1 impairment.
They lack capacity for that specific decision. And you have to document why. You can't just write lacks capacity. You have to evidence which of the 4 abilities they failed on.
To lock this down, let's use the mnemonic scale.
Okay.
S for support understanding first.
Yeah.
C, check for an impairment. A for apply the 4 abilities. L for least restrictive best interest, which is what comes next. And E for evidence it all in the nose.
Perfect. That's the whole process.
So once you've decided they lack capacity, you then act in their best interests.
Yes, but this isn't just what you think is best. It's a formal process guided by Section 4 of the Act.
What does that checklist involve?
It's comprehensive. You have to consider their past and present wishes, their values and beliefs. You absolutely must consult with their family, friends, or carers.
What if you can't find anyone, like in our starting scenario?
That is the trigger for an IMCA, an independent mental capacity advocate.
When do you have to involve them?
You have a legal duty to instruct an IMCA for any decision about serious medical treatment or a long-term move and accommodation if the person lacks capacity and has no one independent to be consulted on their behalf. Spotting the need for an IMCA is a high-scoring action in the SJT.
Right. Let's shift now to applying these laws in some other high-stakes situations, starting with end-of-life care.
A really challenging area.
And the biggest trap the SJT seems to set is confusing a DNA-CPR form with a do-not-treat order.
Yes, we have to be so clear about this. DNA-CPR does not mean do not treat.
What does that mean in practice?
A DNA-CPR order is a very specific decision about one single intervention, cardiopulmonary resuscitation. That's it.
So if that patient gets a treatable infection,
you must treat it. All other appropriate care, antibiotics, fluids, oxygen, comfort measures must continue. To use a DNA-CPR form as a reason to withhold treatment for sepsis is unethical, unsafe, and just wrong.
When you're having these end-of-life discussions, what legal documents should you be looking for?
2 key ones. First is an ADRT, an advanced decision to refuse treatment.
And that's legally binding.
If it's valid and applicable to the current situation, yes, it's legally binding. It has the same force as a capacitated refusal made right there and then. For it to refuse life-sustaining treatment, it has to be in writing, signed, witnessed, and state that it applies, even if life is at risk.
And it only kicks in if the patient lacks capacity now.
Exactly. If they have capacity, they can just tell you what they want. The ADRT is for when they can't.
And the second legal instrument?
That's a health and welfare LPA, or lasting power of attorney. This is where the patient has appointed someone to make decisions for them when they lose capacity.
So that person speaks for them.
They act in their best interests, yes. You have to respect their authority as the decision maker.
Now, you mentioned case law earlier about the duty to involve patients in these talks.
Yes, cases like Tracy and Winspear establish that there's a strong legal presumption that you should discuss DNA-CPR decisions with the patient. If they lack capacity, you discuss it with their family. You can only skip that if it would cause actual harm.
And the absolute red flag here is the idea of a blanket DNA-CPR.
Unlawful. Completely unlawful and discriminatory. You cannot have a policy that says, for instance, all residents in this nursing home are DNA-CPR. Every single decision must be individualized.
Let's use the mnemonic calamar for this.
Okay.
C for capacity and values. A for ADRT LPA check. L for limit DNA-CPR to just CPR. M for use the MCA for best interests if needed. And R for record and review.
A very safe pathway.
Okay, let's move to another difficult area. Resource allocation.
Finite resources. Infinite demand. The story of the NHS.
And the exam tests this with scenarios like you have one isolation room or one ICU bed and multiple patients who need it. The trap answer is first come, first served. Why is that so wrong?
Because it's unjust. It ignores clinical reality. Your decision has to be transparent and based on objective criteria.
Okay. Yes.
Clinical urgency, who is the sickest right now. Expected benefit, who stands to gain the most from this resource. And harm if delayed, who will deteriorate the most if they have to wait. You have to document your reasoning based on those principles.
And this has to be viewed through an equity lens. What does that mean?
It means you have a duty to actively address health inequalities. Fairness isn't about treating everyone exactly the same. It's about giving everyone the same opportunity for a good outcome.
So you have to identify and remove barriers to access.
Yes. Things like language barriers, disability, deprivation. You have to make reasonable adjustments to ensure care is equitable, not just equal.
What about when the whole system is just overwhelmed? When the A&E is full and there are ambulances queuing outside?
That's a test of your professional responsibility. Your personal duty in that situation and the highest scoring action is to escalate early.
You tell the site manager.
You tell your senior, the site manager, the operational lead. You make the system aware of the risk. It's not about passing the buck. It's about triggering a system-level response to a system-level failure. If you don't escalate, you're accepting personal responsibility for that risk.
And while you're waiting for help?
You do your best to safety net the patients who are waiting, and you document everything. The escalation, the risks, the rationale for your decisions.
The mnemonic for this is FAIR E.
I like it.
Focus on need and benefit. Address inequalities. Inform and document. Raise or escalate risks. And establish a review or safety net plan.
Very good.
Okay, that leads us perfectly into the broader topic of removing barriers. Equality, diversity, and inclusion.
Which the GMC is now very explicit about. Let's start with reasonable adjustments. You said it's a legal duty, not just a nice thing to do.
It's a legal duty under the Equality Act 2010. The SJT will reward you for actively identifying and removing barriers for patients with disabilities.
And we're talking beyond just physical ramps.
Far beyond. We're talking about the Accessible Information Standard, or AIS. This legally requires us to identify, record, and meet a patient's communication needs.
So for a deaf patient.
It means booking a professional BSL interpreter for a complex consent discussion. It doesn't mean writing notes or asking them to lip read. For a patient with a learning disability, it might mean providing an easy-read leaflet.
Which brings us back to that massive red flag about interpreters. Why is using a patient's child or family member almost always the wrong answer?
It's wrong on so many levels. It breaches the AIS. It compromises the validity of consent. How can you be sure they've translated the material risks accurately? It puts an awful emotional burden on the family member, and it destroys confidentiality and your ability to check for coercion.
So the best action is always to
postpone if it's safe to do so, and book a professional, qualified interpreter, even if it causes a delay. It's about safety and legality.
What if a patient tells you a colleague made a discriminatory remark?
You have to act immediately. You acknowledge their experience and support them, you document the incident factually, and you escalate it straight away according to your trust's policy. You never, ever ignore it or tell the patient to deal with it themselves.
Let's use the mnemonic IMCA for this.
Go on.
Identify needs, necessary adjustments, clear communication, lift concerns, and escalate. And document and evaluate.
That covers your duties perfectly.
Now let's talk about managing cultural differences.
This is all about starting with curiosity, not judgment. You need to explore a patient's beliefs and values before you even think about proposing a treatment plan.
But you said there's a line where respect for beliefs meets legal and safety boundaries.
There is, and that line is usually safeguarding. If a cultural practice is causing or risking significant harm to a child or vulnerable adult, your safeguarding duty overrides everything else. The law is the boundary.
What about the classic example of a patient refusing a blood transfusion for religious reasons?
If they have capacity, you respect that refusal, 100%. But your job doesn't stop there. Your duty is then to find safe, acceptable alternatives. You get on the phone to hematology, to anesthetics, you discuss blood-sparing surgical techniques, cell salvage. You work with them to find a plan that respects their values and keeps them safe.
And the final, really tricky scenario. A family insists on speaking for a capacitated patient who doesn't speak English, saying, "It's our culture."
Yes. This is where you have to be polite but firm and uphold the law. You acknowledge the family's importance, but you explain that the law requires you to get consent from the patient themselves.
So you get an interpreter.
You get a professional interpreter, you address the patient directly, and you ensure that their decision is their own, free from coercion. The patient's autonomy is paramount.
A great mnemonic to wrap this up is respect.
Okay.
Rapport, explore beliefs, support understanding, propose options, ethics and law, consent and capacity, and traceable notes. Right. We've laid the groundwork. Now let's get really exam-focused. How do these concepts actually appear in the SJT?
They appear in predictable patterns. If you can learn to spot the pattern, you can find the high-scoring answer much more quickly.
Okay, let's run through 4 common patterns. Pattern 1. A patient who seems perfectly fine refuses a high-benefit treatment.
Okay, so what's really being tested there is your respect for capacitated refusal. It's about autonomy and the right to make an unwise choice.
So the best action is?
Confirm their capacity, check they understand the risks and alternatives as per Montgomery, and if they do, you respect their decision, document it, and safety net them.
Pattern 2. The confused, delirious patient who needs urgent treatment, like our sepsis case.
That is a pure test of the Mental Capacity Act 2-stage test.
Best action.
Support first oxygen, fluids, calm environment. Then assess their capacity using the 4 abilities. If they lack it, you treat in their best interests using the league restrictive option. And you document every single step of your thinking.
Pattern 3. Limited resources. 1 bed, 2 patients.
This is testing fairness and justice.
So you allocate the bed based on?
Clinical need, urgency, expected benefit, harm if delayed. You document your rationale, and you must escalate the capacity issue to management and safety net the patient who has to wait.
Last one, pattern 4. A patient who needs complex consent, maybe a child or someone with a learning disability, and you don't have the right support there.
That's testing your knowledge of Gillick or the Accessible Information Standard. It's about valid consent.
So best action is 2.
Postpone the discussion if it's clinically safe. Arrange for the right support, a qualified interpreter, an advocate, an IMCA, provide accessible information, and then proceed with the consent process properly.
Okay, let's talk about the trap answers. The ones that look tempting but will lose you marks.
Right. Number 1 is use the patient's child to interpret. Almost always the worst possible option. It breaches everything we've just discussed about safety, confidentiality, and consent.
What's next?
Assume the patient lacks capacity because they're making a risky choice. This is a direct breach of MCA Principle 3. You cannot equate an unwise decision with an inability to decide.
First come, first served for resources.
A failure of justice. It has to be based on clinical need.
What about applying a blanket DNA-CPR?
Unlawful and discriminatory. Every decision must be individualized.
Ignoring a valid ADRT.
That would be unlawful battery. If it's valid and applicable, it is legally binding.
And only describing the treatment option you prefer.
That's a failure of the Montgomery standard. You have to discuss all reasonable alternatives.
Okay, let's finish with some quick-fire rounds. If X happens, you do Y.
Let's do it.
A 16-year-old refuses life-saving treatment. What do you do?
Seek urgent senior and legal advice. The court can still intervene.
A family insists on speaking for a capacitated patient who doesn't speak English.
Arrange a professional interpreter and address the patient directly, checking for coercion.
You find a note in the records about a possible ADRT refusing life-sustaining treatment.
Verify its validity and applicability immediately. Check it's written, witnessed, and covers the current situation.
A patient with a known learning disability is refusing to let you talk to their family about a best interest decision.
You instruct an independent mental capacity advocate an IMCA.
And finally, a patient reports a discriminatory remark from another member of staff.
Acknowledge, support the patient, document it factually, and escalate it according to trust policy immediately.
Perfect.
So, after all that, if we were to summarize this entire deep dive, I think it comes down to 3 key takeaways for the exam.
Okay, what are they?
First, law first, judgment last. Always apply the correct legal framework, Montgomery, the MCA, Gillick, before you make a clinical judgment. That's what shows structured thinking.
Right.
Second, support, assess, document. You maximize autonomy by supporting understanding first before you even think about assessing capacity. And you record the reason for every decision.
And the third?
Fairness is criteria-led. Decisions about resources have to be transparent and based on clinical need and benefit. And you must actively tackle any barriers that cause inequality.
This has been so incredibly helpful. This content is truly the foundation of safe practice. And mastering these patterns is, I think, key to doing well in the MSRA SJT.
It really is.
And for anyone wanting to practice applying these frameworks to more scenarios, we'd really encourage you to use structured resources, like the ones you can find over at pastmsra.com.
They're a great way to solidify this knowledge. So my final thought to leave you with is this.
Go on.
Remember, the safest doctor is the one who documents not just what they did, but why they did it, with the patient's voice and the law securely at the center of everything.